Hey y'all, welcome back. This week we're going to be talking about progesterone for perimenopause and menopause. This video is meant to be a broader overview as to who may be recommended to use them, some pros, some cons, some of the options that you may run into, at least here in the US at this point in time. I know other countries may have other medicines that are approved there, but not here. And that just gives you some foundational education when you go talk to your doctor about menopause care based on your personal medical history, surgical history, etc. That may be the best for you. So this isn't going to be the nitty gritty, 1 hour long, what are all your options and all exquisitely fine details. But anyway, let's just get started. Why do we recommend progesterone or progestins? And I'll get into the distinguishing factor of that here in just a minute in perimenopause or menopause care. Well, this is for the most important reason, safety. For those who still have a uterus, we want to make sure that if you are getting systemic estradiol, we are also protecting the endometrial lining, or that inner lining of the uterus, which is shed when you normally have a period. And so it would be for protection of that proliferating or growing too much and maybe contributing to something like endometrial cancer. So if a woman has had a hysterectomy, this is not something that is required, though you may hear me talk later about some additional benefits that someone may see or feel when they use progesterone, even if they don't. If you've had, or someone's had an endometrial ablation or something else similar to that where they're not having a period but they still have a uterus, it's still recommended to use one of these forms for protection. And then the other nuanced kind of terminology is progesterone versus progestins. I'll try to keep them straight here in a factual or correct way. I use both, but basically, just for your knowledge, progesterone, something like micronized progesterone, is going to be what is termed like a natural or bioidentical, as some say, hormone, which is basically chemically made up the same as what your body would naturally produce, whereas progestins, or the synthetic, however you may hear it termed, progestins, they're going to be similar or functionally related and have some similar outcomes. You may also see that some progestins act a little differently than others, just how they're chemically made up. And that's not to say that one's, always good and one's always bad. They all have their different pros and cons, which we'll touch on a little here. In the hormone menopause space, you may hear some of those terms thrown around more as like a marketing pitch or something like that, but it is something that I just want to bring up if you hear me say one thing versus the other. Anyway, let's get started. The first option that is probably my most commonly used is micronized progesterone. This comes in a capsule, and this is an FDA-approved med here in the US. It is usually very affordable. It has a couple different doses, and I'll get into that in a minute. The big thing I like to ask patients about, and thankfully it doesn't happen very much, but I'll ask if they have a peanut allergy, because the capsule's made out of peanut oil. So if someone has an anaphylactic allergy, then that is some time when I would have it compounded. But like I said, I rarely ever run into that issue. Thank goodness. I love peanut butter. I eat it every day. So I would not like to have a peanut allergy. But anyways, I digress. The micronized progesterone is usually very well tolerated. If someone is going to have a side effect, I may tell them they would have sleepiness, which we'll get into a potential pro in a second. Maybe a little bloating, that some people could have that while they just get adjusted and then they're fine with it. So if you don't mind taking a capsule once a day at bedtime, this is a very good one. At the doses of 100, 200, you can get different benefits. 100's maybe less negative side effects, but 200 would be better endometrial protection, especially if your systemic estradiol dose is a little on the higher side, or you're still having trouble with sleeping. So that's just something, just depending on your regimen too, that you and your doctor can figure out. If you're going to be taking it every single day, 100 may be okay at a lower dose estradiol. If you do all right, if you're going to do a cyclical pattern, which depending if you're still having periods or not, how are your periods, are they very heavy, what have you, that might be a good method to talk to your doctor about doing it more cyclically, but doing it at a higher dose at 200. Though at that point, the nice thing is a lot of my patients going through perimenopause and menopause get sleep issues, trouble not necessarily falling asleep at sometimes, but I feel like the waking up at what I call witching hour, 2, 3, 4 a.m. is a very common thing I hear, and so this can help with sleep. And if you're doing it cyclically, 12 to 14 days a month versus every night, well, then you may not get that benefit every single night, obviously. So those are some pros and cons. Because it's a little more gentle, it's not as strong of a endometrial protector as some of the other ones. It's also not as much of a breast side effect if you're thinking of like hormone sensitive tissues there. If someone were to get breast cancer, this one's not as potent. So anyways, that's micronized progesterone. Very affordable, probably like my most commonly used one. I will say it does not work for contraception. So if someone's in perimenopause and they still are sexually active with someone of the opposite sex and they can have a baby but they don't want a baby, which most of them don't at that age, then that is something that it can't really help you with, is contraception. But the next most commonly used thing that does help with that, I love to use, is a levonorgestrel IUD. This could be something like a Mirena or a Liletta. And it's contraceptive purposes. You know, you get a little more lifespan out of an IUD, one of those like 8 years, 7-8 years, but for bleeding or endometrial lining protections closer to 5 years. It is really nice if you can afford it or your insurance covers it and you like the idea of a sit and forget method of having just the IUD placed. And this is something I do in our office, not all the time every day, but pretty regularly, and it also helps with bleeding control as far as periods go. So for a lot of my women, they're having irregular or heavier periods, so the idea of getting the contraception taken care of, the bleeding getting better, not having to take a pill every day and just sit it and forget it for years to come is super tempting, which is probably why I do a decent amount of IUD replacements or placements in these women. So some cons, it can be a price issue. If I do have patients, because I do see a lot of patients that don't have insurance or are underinsured, then we try and do a patient assistance program, and I've had many of them get approved for that where it's covered. I have had one recently that unfortunately, we couldn't get her covered and her insurance wouldn't cover an IUD, so the cost on that can be kind of prohibitive. But, if you can get it, it's great. The procedure itself, just for someone who, primary care like family medicine, OB, women's health trained people, we do them a decent amount and it doesn't take that long. We can talk about pain management options and everything like that. And for me, I'm in a direct primary care setting, so I'm not charging extra for a procedure fee or anything like that. So anyways, I really like them. You can have some negative side effects. You can have a spontaneous expulsion of an IUD prematurely, which I've had a patient have that happen before, unfortunately. So we had to think of another method for her because that was her second IUD. But anywho, if you can tolerate it and you like all the benefits, and I've never, I've been able to do IUD placements very comfortably for many, many patients. I think it is a very good choice, so I would really highly consider it. Anyway, let's move on. There's other pill options, and this is where you can go down a big rabbit hole, so I'm just going to keep it brief and just some oral options. So most of these are a pill once a day for however long you need to do it till you truly are in menopause. And we maybe can switch what type of pill it is for birth control purposes, or if someone has a hysterectomy or something like that. Anyways, some birth control pills will provide some endometrial protection. Obviously, there's some pros and cons to that. As you get birth control level of hormones in the body, you obviously aren't worried as much about contraception, but you have some other side effects like blood pressure and things you want to keep an eye on. But you can get some benefit there. One birth control option I think is a really nice idea, something like Slind, which is drospirenone. It's a better progestin only birth control pill, so someone's more sensitive to the estradiol component of a birth control pill for whatever reason, then they may like it. It's better than the progestin only pills that you think of, like if you're getting sent home from the mom baby floor after having a baby. So you get a little bit better birth control protection, and also not as strict as the timing. Say you miss it by a few hours for this, you're okay. And it can be pretty affordable too with certain insurance plans. Cash pay, it's a little more expensive per month, but if you're trying to hit two birds with one stone, technically it's not like FDA approved for endometrial protection, but it can kill two birds with one stone. And it does have some more anti-androgen effects. So say someone's going through perimenopause changes with hormones and they're getting more acne or something, maybe that can be helpful. It's related to spironolactone, so I wouldn't double up too much in medicines that overlap in that way. Watch electrolyte levels and things like that. But there are some other pill options that can be considered that are synthetic progestins. Take every day, can provide some birth control benefit too, etc., etc. They may, because they're a little stronger potency for endometrial protection, may be a little stronger on the breast tissue as well. So that's just something to keep in mind. But anyway, those are some pill options that you have. Say you're really scared of a procedure, or you just don't want to go through that, or whatever. Anyways, there are some, these I don't really use as much, patch options, or I guess I should say one pill option that I just don't use a lot. I have it in my repertoire. It's just between cost and other options, I usually don't use it, but Duovie is actually a decent option. It's got a conjugated equine estrogen, and this isn't talk about estradiol today, but it's actually progestin free, so I don't really know where else I put it in the video, but it is progestin or progesterone free pill. It's got beta-doxaphene, which is a serum, 20 milligrams in it, and so you take it once a day and you do get good endometrial protection from it and some bone benefits too. So let's just say someone is having an allergy or really just sensitive to progesterone or a progestin, that could be a good option. Or maybe someone's had a hormone sensitive medical history where they're trying to avoid it for other reasons. So I'm glad I didn't forget to mention that, though I don't use it a lot. It is actually a decent option for the right candidate, and that's again why you have to have a good relationship and rapport discussion with your doctor, because I'm probably not your doctor. But anyway, going back to some patch options, again, I don't really use these a lot. A lot of that is related to cost, and as we get into the transdermal progesterones or progestins, I should say, absorption and things is just a question. I don't know that it's as reliable for endometrial protection. In some cases, it depends on the medicine too, but you could consider someone who's really trying to minimize their medicine list amount or pill medicine burden if they don't want an IUD. So let's just say you have a Comba patch or Climera Pro. Those are name brands, but they will have a combination of a progestin, whether it's levonorgestrel or another, with the estradiol as well, in the same patch that would get changed, again, depending on the patch and the brand and whatever, maybe once a week or so. So that's an option, not something I'm using a lot. I'll say I'm using the progesterone, micronized progesterone, and the IUD, probably the two most common I'm using, especially using the micronized progesterone more. Like I have a lady who's had a hysterectomy, but she's still struggling with sleep, as we've done other hormone therapy options. It, theoretically could be a little helpful too with anxiety. And some of that, maybe there's some GABA properties to it. But also, I just think if you're getting better sleep, you're going to have better emotional regulation, less overwhelm, stuff like that. So I think it's a little multifactorial, but I obviously can't speak from experience myself. I'm just speaking from talking with patients. And quite a few women have trouble sleeping when they go through perimenopause and menopause. So that's progesterones. Who's going to need them? Those who are with a uterus. They may choose different routes based on need for period control, contraception, side effects. Some IUDs not going to really help you with sleep because it's more local effect, not systemic, whereas micronized progesterone is systemic if you take it by mouth. But yeah, I hope that was a helpful rundown if someone is watching this and just is wanting a blanket foundation to start the conversation. And then with your doctor, you can always go from there. If I'm missing anything or you have any questions about it, please drop them in the comments below. I'd love to hear them. And if I need to do a follow-up video, then I can do that too. All right, thanks. I will see y'all again next week.